Thank you so much, Caroline, for that introduction. And thank you all for being with us today for our Task 90 on car finance post COVID. And of course, we're all tired of hearing and talking about, and we're ready to put COVID in the past. But the reality is it's been a dynamic last few years for us. There's been a major evolutions and rural health and the healthcare industry since then. We've got a lot of lessons learned from that, and we still have some challenges we're facing ahead. So we've got a certainly a complex environment that we're navigating, and the intent of this webinar is really to help equip all the flex coordinators to make the most strategic investments they can to be really exceptional fiduciaries of the federal funding when it comes to finance and ops, particularly for the next funding period. So we're hoping that we got a great lineup of speakers today, and we're hoping that you all gain some perspective and insight that really helps set you up for success in that. So our objectives today are we're going to walk away with this with recognizing and really a level set for any new coordinators that are here regarding the how financial indicators and how they relate to hospital financial sustainability, particularly in the post-COVID environment. We're going to help to ensure that everyone here is able to access and really analyze the relevant financial data that will help equip you to make better decisions to support CAHs. And then we're going to help really build your capacity around enhancing your financial management strategy for your states and really support a really intentional investments within your flex finance and ops work plan. So with that being said, we've got some exceptional guest speakers with us today. We're going to start with the federal partners updates. Then we've got a team from FMT and University of North Carolina, Chapel Hill. We've got the finance and ops leads from Strywater Associates on the call with us today. And we've got CAH administrators. You can hear from in the trenches firsthand what they're doing, two high-performing CAH administrators from both Dallas County Medical Center and Washington County Hospital Nursing Home with us today. They're going to test what they have found to be highest value, where they're focusing their strategy on to face the future. And then we'll wrap the end of today's session up with some Q&A and really some conversation about what are you all doing to really have the best possible outcomes of your investments related to finance and ops. So with that being said, we'll give, let's see, we can start off with HRSA updates. I believe Laura's not with us today, but I know we got Kathleen Connors de Laguna is on a call with us, and Courtney Turner. If you have some updates for us, we'd love to hear them.
Sure, it's Kathleen. Hello, everyone. Laura is enjoying a well-deserved vacation, so she did ask me to give two updates for any of you who don't know that the Flex NOFO and the EMS Supplement NOFO, they're both out, and you should have received many emails with resource information about those, as well as the technical assistance webinars. If not, please contact our friends from Task. And now I'm going to turn it over to my colleague, Courtney Turner from our policy group.
Kathleen, and good afternoon, everyone. I'm Courtney Turner, and I am now the policy coordinator here in FORHP. I was asked by Laura to provide some updates on any policies that may be relevant to this group. And so there are just a couple, as well as a webinar update that you also received an email from Laura a couple weeks ago soliciting questions. So I will get to that. So the first policy that I want to just bring to your attention is that CMS released the interoperability and prior authorization final rule in January. And this rule advances federal efforts towards interoperability by addressing electronic exchange of health information and prior authorization processes. The GAO recently found that the use of electronic exchange methods among small and rural hospitals is lower than that of other hospitals. And so some highlights of the rule, effective January 1 of 2027, there's an electronic exchange of health information, and in that, issuers of Medicaid and children's health insurance programs, also known as CHIP, those fee-for-service programs, Medicare Advantage organizations, and qualified health plan issuers on federally facilitated exchanges are required to implement and maintain application programming interfaces, or also known as APIs. These interfaces must use global standards for the electronic exchange of health information, and the APIs must facilitate data sharing under specific circumstances with patients, between payers and providers, and between payers themselves. Another portion that we like to bring to your attention is the streamlining of electronic prior authorization. So in 2026, this will impact insurers, that insurers must send authorization to providers within 72 hours for urgent requests and within 7 calendar days for non-urgent requests. Beginning 2027, impacted payers must implement an approved API. So API being application programming interface for prior authorization, where providers can access the list of covered items and services and get support with their requests. In addition, in 2027, hospitals, including critical access hospitals and merit-based incentive payment systems, eligible clinicians will have to attest to using this electronic interface to submit prior authorization requests as part of their Medicare Promoting Interoperability Program reporting requirements. One of the positive things here about this rule is that over the years, hospitals have honestly been very forthright in complaining about how MA plans in particular have been really slow on their prior authorization responses. And one of the things that CMS did note in the rule is that they are hoping that a universal rule and actions and expectations will help eliminate the lag.
Yes.
I think someone's not on mute, so please mute. Thank you. CMS believes that this will help universalize the responses of prior authorization requests, and it will also help physicians with the new interfaces to go in and see what is the probability of something being approved or not, or what is the history of approval per provider. And then that way, providers as clinicians and even some patients, if they have the technology, can see what the authorization status would be for something that was submitted for their care. The next item we wanted to bring to your attention is there's a new Medicare Learning Network guidance on billing requirements for intensive outpatient program services for federally qualified health centers and rural health clinics. So this MLN guidance gives an overview of the new intensive outpatient program services that will begin that has begun January 1. So Medicare began the coverage and payment for IOP services that FQHCs and RHCs provide for people with mental health needs in particular. Highlights of this is that an IOP is a distinct and organized outpatient program of psychiatric services you provide for patients who have an acute mental illness, which includes but isn't limited to conditions such as depression, schizophrenia, and substance use disorders. CMS will pay for IOP services provided at the same payment rate as if it were provided by a hospital. And additional information on IOP services within this includes scope of benefits, certification and plan of care requirements, payment policies, and coding and billing requirements is also included in this recent guidance. And for those who are not familiar, this new this new payment provider type was approved in the most recent rules that came out for IPPS and OPPS. Well, really it was OPPS. So you can go back and look at the final rule or access this information on CMS's website. They have really great fact sheets about this. And if you have any questions, feel free to email me at ruralpolicy@hrsa.gov. And I'll put that email in the chat. One other item that we wanted to bring to your attention are new actions to help hospitals meet obligations under EMTALA. And EMTALA is the Emergency Medical Treatment and Labor Act. CMS, in conjunction with HHS, are launching a series of actions to educate the public about their rights to emergency medical care. This series was developed in response to a growing number of inquiries from patients and providers that CMS received about how to ensure that federal obligations are met under EMTALA. And so the comprehensive plan that the department will engage is publishing new information resources on CMS's websites to help individuals understand their rights under EMTALA and the process of submitting a complaint if they are denied emergency medical care. The department will work with partnering with hospitals and provider associations to disseminate training materials on providers' obligations under EMTALA, convene hospital and provider associations to discuss best practices and challenges in ensuring compliance with EMTALA. So that may be future open door forums. They weren't very specific about that, but do look out for those notices of future webinars or open door forums about this. And finally, the department through CMS will work to establish a dedicated team of HHS experts who will increase the department's capacity to support hospitals in complying with federal requirements under EMTALA. If you go to the website that CMS has, which I will also put in the chat, take a look at the images that CMS uses, and that might give you an idea of the concerns or questions that they may have received in terms of being compliant with EMTALA. And finally, there is an upcoming webinar that we are hosting through RHI Hub. It is going to be on the calendar year 2024 physician fee schedule. And it will be Tuesday, the 27th of this month at 3 p.m. It'll be approximately 90 minutes. RHI Hub will be hosting it. So when the information for registration comes out, you will go to RHI Hub's website to register, and we will put it in the Fork weekly announcements. CMS staff will provide an overview of select physician fee schedule topics, and they are telehealth, behavioral health, some of the new billing codes, Medicare diabetes prevention program will also be covered, and RHC and FQHC updates. And the webinar will also include questions and answers that will be addressed by CMS staff. So please have a look out for that. I will send Laura the information when it does come out. So she will send it out through the Flex listserv. And I am complete with updates. I will take any questions if there are any at this time.
Thank you very much, Courtney. There's exciting news about the evolution of interoperability and the MA plans. That's been certainly high priority for all of healthcare, especially consideration for rural. So that's great to hear that. IOP, behavioral mental health, is not going away. That's exciting too. And of course, EMTALA is no one's immune to that. So it's certainly something that is exciting to hear. And we'll certainly be on the lookout for Laura to relay further correspondence and communications as it comes through. Please feel free to utilize the chat for any additional questions you have. And if we don't have time to get to them, we'll certainly circle back and follow up with any of you after the call today too. With that being said, wanted to give Telegen and Arquita a moment for their updates. We've got a few exciting things to share. And let's see, Lana, or
yep.
There we go.
Hi, everyone. Just some quick updates about what the Arquita team has been working on. We have a new resource, the Arquita Quality Improvement Workbook. This is a great resource with general quality improvement tools, not MBQuip specific. In there are worksheets, tools, processes in the workbook to help you or help hospitals work through quality improvement projects to help ensure effectiveness and sustainability of your QI efforts in hospitals. Something else that is new, we recently launched the Arquita Telegen website. This website is host to quality improvement tools relating to MBQuip domains and MBQuip content. So go and check it out. There are wonderful QI resources over there. You will still find all of the MBQuip data reporting tools and MBQuip resources on reporting on the task website within the MBQuip toolkit. We are working with the task team to create linkages to the Telegen quality improvement tools onto the task website. So be on the lookout for that in the future. other activities we are working on. We know you are all working on getting hospitals in your states prepared for reporting the MBQIP 2025 measures. We are working on measure submission guides for the MBQIP 2025 measures, which will include instructions on submissions, including screenshots and tips and tricks for reporting. So we think this will be a great tool for you and then also for the hospitals as well. We are working on a recorded presentation of the MBQIP 2025 measures. This recorded presentation will review all of the new MBQIP measures, including reporting details and deadlines and how hospitals can begin to prepare for reporting. And finally, we are working on a quality improvement basics recorded webinar series. This series will be great for state flex programs and for hospitals who are new or unfamiliar with quality improvement basics, or for folks who want to strengthen their skills and understandings of quality improvement. So some really exciting stuff in the works. So feel free to reach out to the ARKITA team if you have any questions. Thanks, Nick.
Excellent. Thank you so much, Lana. All right. And as far as from the tasks side of the house, we've got, of course, we're here and able to help you all in fine tuning and really polishing your submissions for this year's NCC. We've got of course, what it's limited to one section within your actual application for us to review, and we're happy to assist you with that. And we're looking at really by April the 2nd is the time frame for it, and April the 11th for the EMS supplemental funding. So also consider the NOFO questions that you do have. Chances are there's also other states are thinking the same thing. So particularly when it comes to this competitive cycle, we've got lots of people with the same questions. So don't hesitate to utilize the forum and post your comments there, and we can all learn collectively from those responses and how that gets triaged. So we've got a evaluation webinar series coming up on February the 20th. That's the 5th one, and it's been fantastic. Those of you who hadn't had a chance to review that evaluation webinar series, please go back and watch those, and also attend the 20th if at all possible. And we also have our open office hours on February 26th and March 12th. And of course, correspondence has recently been posted regarding this spring flex workshop. Any of you coordinators that are interested in attending that, please consider completing that request form. So with that being said, I'm going to now pass it to our partners at FMT and University of North Carolina at Chapel Hill. We've got Christian Ryder, and which is a esteemed professor there at UNC and a Departmental Health Policy and Management Chair. And with Kristen is Laura McFadden, and she's a MSPH intern that will be helping to really articulate what FMT and Compass is showing us as far as the trend and what's happening in rural right now. So, and I can run the slides for you if you like to, Kristen or Laura, whatever's easier for you. Okay, take it away.
Yeah, that works with me.
All right.
All right, Laura, whenever you're ready. Thanks so much, Nick. Really good to be here. I'm going to let my colleague Laura start, and then I'll jump in a little bit. So Laura, take it away.
Perfect. Thank you.
Yeah, thank you so much, both. I'm so glad to be here. So yeah, this is just going to be a presentation on monitoring critical access hospital financial performance, just post the COVID pandemic and how financial performance has changed throughout the past few years. And of course, we love to thank our funders through the Office of Rural Health Policy. Here's just our agenda for the day. So first we'll talk about just financial performance trends before the pandemic, during the pandemic, and then after the pandemic, as well as, great. Yeah. Okay, so since January of 2005, 67 critical access hospitals have closed or converted. 38 of these were complete closures and 29 of these were converted closures, where critical access hospitals still provide some form of healthcare like primary care or skilled nursing care, but the conversions, they do not provide any inpatient services. Most of the hospitals that closed between 2017 and 2020 were also characterized by being less profitable and less liquid, so that they were able to less likely able to convert assets into cash compared to ones that remained open. So now rural emergency hospitals are serving as an alternative to complete closure, and 6 of the 19 hospitals that converted to this status in 2023 were actually critical access hospitals. So instead of ceasing to offer any healthcare services, these hospitals are now authorized to offer emergency department services, observational care, and additional outpatient services. This new payment designation is hoped to slow the rural hospital closures trend. So in the coming slides, we'll look at 2 measures of hospital profitability: operating margin and total margin. These measures will be shown both with public health emergency funding and without this funding, as shown in line 2 of the table, to portray the financial situation of hospitals would have faced in the absence of government funds. Public health emergency funding refers to the CARES Act funding, such as Provider Relief Fund and the American Relief Plan. So first, we'll talk about operating margin, which measures the control of operating expenses relative to operating revenues, and basically just refers to revenue and expenses accrued from patient care. And so next, total margin is a broader measure compared to operating margin, and it also includes all income from non-operating sources such as contributions, investments, and government transfers. And so together, we often refer to total margin and operating margin as measures of a hospital's profitability status. And these measures are really helpful in predicting financial distress and likelihood of closure for hospitals. And so the graph in the bottom left showcases median critical access hospital operating and total margin, where operating margin is in red and total margin is in blue. And this is between 2015 and 2022. These measures include public health emergency funds that the hospitals received. And as you can see, portray like a really sharp increase in profitability between 2020 and 2022. However, though, these funds likely mask some real financial challenges that were experienced by critical access hospitals. For instance, you can see on the right, operating margin without funds was negative 0.3%, which is 7 percentage points lower than with those funds. And then similarly, total margin would have been 1.9% without funds instead of the current 9.4%. So in the absence of funding, critical access hospitals' financial situation would have looked a lot different. And then furthermore, the graph below is really similar to the previous one, but the thing that's most different is that this graph shows the most current year of data, so 2022 through 2023. And then in this most recent year, you can see that profitability has declined pretty sharply back to around pre-pandemic levels. And so while we can see that the public health emergency funding served its purpose by sustaining hospitals throughout the pandemic period, the effect of these funds is now starting to wear off. And then this final graph only is portraying operating margin, and operating margin with the public health emergency funds included is in the red, and then without those funds is in the purple for years 2015 through 2023. And so you can see in 2020, these lines diverge, and we can clearly see what critical access hospitals would have experienced without those government funds. And it's important to note that while these funds were helpful, they may have masked those longstanding challenges that we all know that critical access hospitals face. And then also that margins now appear to be trending downwards towards the pre-pandemic trends of close to around 0, and some like even in the negative. And this trend has been declining over time. So this is something to be mindful of in the future as we continue to monitor critical access hospital performance.
All right, thanks so much, Laura. I'm going to pause before we move on and just see if anyone has questions for Laura about any of the data that she talked about. All right, well, hearing none, then we'll keep going. We're going to talk a little bit now about the post-COVID environment and just very briefly cover some of the data that's available in the Critical Access Hospital Measurement and Performance Assessment System. Many of you have probably seen this before, so I won't spend a lot of time on it, but I want to just walk through and provide some updates about when data will be updated, what's there, and what you might look at. So as you all are aware, hospitals continue to face really ongoing challenges in the post-COVID environment. We're seeing lots of things nationally, the continuation of the workforce shortage, both providers and nursing, and recruitment being a challenge, and raising really the salaries that need to be paid, and a lot of reliance on contract labor. In addition, inflation and supply prices continue to persist, and so that is really challenging financial performance for hospitals. Some hospitals are struggling to see volume come back, particularly on the outpatient side, with people kind of used to telemedicine and video visits and other things. And then lastly, liquidity continues to be a challenge with low cash and revenue cycle challenges. Next slide, Nick. So you all probably are aware that Compass is a free online tool for monitoring financial performance that you all have access to, as well as your hospitals. Sorry, I see a question in the chat. Give me a second. Will FMT data reflect COVID funding so we can see how COVID funding impacted your hospitals? Yes, the Compass data do include the COVID funding. So all of the measures you will see are actual measures that are reported, and we do try to highlight the periods during which those COVID funds were present, so that you know what that period was and can look at those indicators. In addition, we have a brief that talks about the impact of COVID funding on each of the financial indicators in Compass that can give you kind of an overview of what those funds did during that period of time. Next slide, Nick. So Compass data, as you all know, again, come from the Medicare cost report. We get a lot of questions about when hospitals will roll into Compass. So I wanted to provide this table. It's a good reference point so you know what's happening. So we update the data in Compass twice a year, once in September and once in March. March, we call our big complete update, which gives us complete data from 2 years prior. And this is really dependent on the release of the cost report data. So in March 2023, we did an update that included all data for 2021 and partial data for 2022. In September, we do a mid-year update that includes partial data for 2022 and partial data for 2023. And then when we update in March 2024, you'll see a complete year for 2022, partial for 2023. The reason we wanted to show this is sometimes folks go in and are missing half the hospitals in a state. That typically is because those hospitals' reporting periods are after the point in time in which we have updated. The other thing to be careful of is if you are using Compass in that September period or using Compass data for a year where only partial reporting has happened, some of the data can look highly variable, especially in states where there's a small number of critical access hospitals. So you might see something look like a big outlier, and it might be reporting just by only a single hospital. Just something to keep in mind. Next slide, Nick. We do have peer group factors in Compass that allow you to compare apples to apples. So you can choose from among these individually or in combination. The one thing to note, you can't choose something in all of these categories typically, or the sample size will get too small. But you can look by geography, so by state, by individual hospitals, you can look by region, you can compare hospitals based on size as measured by the amount of net patient revenue, by government ownership versus other types of ownership, whether or not the hospital operates a rural health clinic or provides long-term care, and finally, whether or not the hospital is affiliated with a health system. Next slide, Nick. I also want to make you aware, in case you haven't seen them, We have quite a few ancillary products on the Flex Monitoring website. One, every year we publish an annual report that includes medians by state for each of the indicators. And in 2023, we redid the entire report. So it now includes visualizations and things by region and more granular data. It's a very large report, but it allows you to jump around in the PDF document. So I don't recommend printing the entire thing. It's probably about 150 pages, but it gives an overview of information. And unlike Compass, this state medians report is available to everyone. It's publicly facing on the website. So if you want to share data and you don't want to share your Compass data, you can always refer people to this. We also have some tools to support state flex programs and hospitals in using the Compass data. We have a series of presentations that help you interpret the data and also give you kind of a baseline if you want to present any of the data. We have a calculator for hospitals or states that may want to use more recent data to calculate the financial measures. So if you want to add to what we have in Compass, it provides all the formulas we use to construct our measures so you can update with more recent data and add to what we have available. And then lastly, there's a whole series of Compass tutorials, both downloadable PDFs and videos to help you know what's in there. Next slide, please. Just quickly, I wanted to run through the categories of indicators and the indicators that are in Compass, and also maybe point out some that might be useful for monitoring some of the factors that we talked about. So the first category of indicators are financial performance indicators. In this category, we have 3 different buckets. So the first is profitability, which includes those 2 measures that Laura talked about, total margin and operating margin, as well as cash flow margin and return on equity. We have a second bucket, which is liquidity. This is going to be incredibly important in this post-COVID environment, kind of monitoring in the short term what's happening with cash reserves and revenue cycle in critical access hospitals. And then finally, we have a capital structure category, which is various measures of hospitals' use of debt financing and their ability to pay that debt financing and the debt service that comes along with it. Anything in bold that you see here is part of the National Rural Health Resource Center top 10 indicators. So if you're looking for go-to measures, you might want to start with those. Next slide, Nick. Within service line, we have additional indicators that can that help you measure inpatient and outpatient volume and costs. So on the inpatient side, you can measure the percentage of inpatient business coming from Medicare. We have the Medicare inpatient cost per day and average daily census measures for acute and swing SNF beds. Very good measures of out or inpatient volume. And then on the outpatient side, we have a measure, again, of payer mix to look at how much of that revenue is coming from Medicare. We have a measure of how much of the overall revenue of the hospitals coming from outpatient, with outpatient being really a lot more important than inpatient for most hospitals right now. And then lastly, the Medicare outpatient cost to charge ratio. Next slide, Nick. We also have measures that help you monitor operations of the hospital. So some of the labor indicators might be very relevant, monitoring some of the increasing costs for nursing and other labor. We have 3 measures here. So FTEs per adjusted occupied bed, average salary per FTE, and salaries to net patient revenue. So how much of that revenue is going to pay for that labor? We have some growth measures to look at changes in operating revenue and expenses. So hopefully seeing the revenue growth exceed the expense growth to kind of give you some leading indicators of what might be happening in the future. And then we have a catch-all category of other measures. So average age of plant, patient deductions, Medicaid, payer mix, and uncompensated care to help you monitor, again, what's happening with insurance and other things in the hospital. Okay, next slide, Meg. All right, that's all we have. We just wanted to make you aware, kind of review what's there. As always, like Nick said, if you ever have questions about Compass, difficulty accessing it, need tutorials or information for your hospitals or login information, you can always contact us at FMT and we will get that information to you. We're always happy to talk to you and answer questions as well. And I will take any before Nick turns it over to our next speaker.
All right. Feel free to use the chat too for our any questions you all think of, or always reach out to us even after the webinar. We're happy to circle back with anything that you need clarification or have additional questions on. Thank you both so much for that status update. And I just want to reiterate, please use all the resources that we just dropped a bunch of them in the chat here. But the expectation from the Flex related program as a whole and across the country is that the coordinators are leveraging this data. This Compass data is a fantastic tool. Please familiarize yourself with all things CAH finance and learn what key indicators are that directly impact your specific demographic of your state. Use that. I know we talk about it being, retroactive or descriptive only. Use those analytics to build out your prescriptive. How are you going to face the forward thinking, and how are you going to really impact what historically is telling you is your highest priority? So please do your homework, do your research, study this stuff, and then work with your state's stakeholders to develop a really exceptional strategy moving forward. So with that being said, we've got some lead consultants here that's really what they specialize in. So I'm excited to have both Eric Shell and Lindsay Corcoran are two of the finance and operational leads for all of their strategic action planning and board education and all things CAH finance and ops from Stratford Associates with us today. So hello, Lindsay.
Hey, Nick. Can I switch to my screen? Do
You
mind?
certainly can.
Okay.
Let me stop sharing.
Okay, sorry. Thanks.
Go right ahead.
I'm just gonna. It's a control thing. No, I'm just teasing. Okay, well, welcome everyone. Thanks for having us.
Hey, can I interrupt you real quick?
Yeah. we can-
Nick, I had
Yes,
to
sir.
I had to call in on my cell phone,
Yes, sir.
the 207 number, a speaker.
We won't mute you, Eric. We won't hold it against you. Thank you for connecting with us today. We're excited to have you both.
All right, well, we'll get started. I'm going to turn it over to Eric to kick things off for us. But really, we wanted to provide you with some kind of, what are some critical access hospital kind of financial challenges? What's happening out there? And kind of Eric's going to set the stage, and then I'm going to wrap things up with maybe some key strategies for you all to maybe consider and think about as it relates to finance and ops.
Okay, can everyone hear me?
Yes, you're good.
Okay, great. I'm calling greetings from the Buffalo Airport in Buffalo, New York. So my AirPods chose not to connect to my computer today, so I'm scrambling here. But so let's just talk a little about kind of finance and payment. And I like to start kind of our section of this meeting off with this comment that this premise that form follows function follows payment. And it's important to understand that, and let me explain that. So, what we're saying is you organize ourselves, our hospitals organize themselves around maximizing the functional imperatives of the payment system that exists. So to start off with, we live in the fee-for-service world predominantly right now, although more and more that's moving. In a fee-for-service environment, the functional imperatives of a hospital are to increase volume, increase price getting paid for volume, and reduce expenses. And an individual hospital operating by itself can be successful there. And so what we got, the form that we got out of our healthcare system was primarily independent organizations competing with other independent organizations based on market share. And the issue here is this payment system that's been static for the past 50 years, fee for service, is changing right now. And it's changing to more of a population-based or value-based payment system in which the functional imperatives are completely different than what they are today. And so for example, if we're starting to get paid on a population health, the hospital I was at today, south of Buffalo here, they get 50% of their primary care revenue in the form of a capitated payment amount. It definitely changes the incentive. And so now the imperatives are, one, to accumulate enough population to diversify insurance risk. And second is to manage the entire care spectrum, both the health and the sick care of a patient, focusing on health. Those are very different functional imperatives of a fee-for-service payment system. One that requires, and it's the second bullet under form, aligned organizations competing with other aligned organizations for covered lives. So I just want to start this off by saying, finance is really important because to some degree, finance defines what we do and how we look. So with that as an opening statement, let's kind of take a look at what I'm seeing out there and kind of what I would say current trends, but maybe not so current. So Lindsay, maybe you could advance for me. So our important, this frame of reference that we use when we're helping hospitals, I think is so important. And it's essentially it's about contribution margin and understanding what incremental volume means to an organization. And kind of critical access hospitals are successful when their commitment centers on abundance, growth, and incremental contribution margin. And so what is contribution margin? If you look at the graphic on the right, when we're living, our hospitals, 80 to 85% of our cost structure is either fixed or step fixed, meaning incremental volume. You get paid $1. Your variable cost is the dark green in the graphic. It's 20% or even 15% of the total revenue, and fixed costs as the other. What contribution margin is it's essentially what's left over when you deliver a service. You get $1. Your variable cost of providing that service is 20 cents. What's left over is 80 cents. That 80 cents is left to cover all of the fixed costs, which you see in the far right graphic, and well as profit or loss, depending on how the hospital is doing. And so, I say this because this, again, like the first slide, it kind of sets the frame of reference for how we think and how I think all of you ought to be thinking about when you're helping the hospitals out there. So, and an important comment here is, again, this inverse is true in value-based risk contracts, that to the extent that we maintain services in-house, if we're under a population or capitated payment arrangement, if we're able to maintain a patient service in our hospital, we essentially create an 80% contribution on it. If we got to refer that out of our hospital, then essentially we're paying for somebody else's fixed costs and we're also paying for ours. So this whole idea of fixed and variable costs and contribution margin being defined as revenue less variable cost is really important understanding because it sets the stage for how we think about improvement in rural hospitals. So next slide, Lindsay. So, funny, I just had a call with a reporter from New York City on Tuesday this week. And we were talking about, kind of what are the things that you see that allow rural hospitals to be successful versus those that tend to be less successful. And in the hundreds of thousands and millions of miles that I've traveled over the last 27 years, what I've really come down to is that there's three key pieces to success within rural hospitals. The first starts off, and it comes out of Stephen Covey and his abundance mindset. And when I'm talking about abundance, it's abundance versus scarcity. So I present these four values. I look at these organizational values. These are our Stroudwater's values: impact, make a difference, interdependence, that we're all just a small cog in a big system, and we all try to respect and take care of others as well as ourselves. Respect, and then this last one, and I think this last one is the most important. It's abundance. And what I've seen is in rural hospitals, generally, I'd say 15% of rural hospital leaders are truly abundance focused. Okay, so what does that mean? All right, so let me compare and contrast scarcity versus abundance. A scarcity mindset, there's a pie of success in this world. And Lindsay, if you're successful, or Nick, if you're successful, the pie just shrunk for me, right? Scarcity mindset. You just took a piece of my pie. And I don't like that. I like all my pie. And so what I'm going to do is I'm going to do things to keep you from taking some of my pie. I'm going to hoard information. I'm going to hoard. I'm going to keep you out of meetings. All of these things. On the other hand, abundance says that if Nick and Lindsay, they're successful, that pie grew for everybody. And an abundance leader is 100%, is 180 degrees different than scarcity. And what I've found is organizations that are led with abundance, and I could give you 10 examples of CEOs that have come into organizations that were cratering, and with this abundance mindset, they focus on growth. They focus on they focus on sharing credit, giving other people credit, and they get a whole team of people working for the organization's best interest. And so I look at, if we're talking about the 3 keys to success, the first is an abundance leadership model. And I think first and most important. The second, Lindsay, is the next slide. The next is fundamental understanding of economics. We kind of tipped our cards a little bit on that slide with the graphic around contribution margin. And it's this idea, the leaders in organizations that truly understand what drives their profit, or in most cases, reduced losses in those organizations, fundamentally understanding the economics of their hospital is so important to success. And it gets back to this idea that variable costs are so small in a rural hospital. Variable costs, as a definition, are costs that change with changes in volume. So if we admit a patient this afternoon, what did our costs really go up? Well, we probably gave them some meds. We probably gave them some food. We turned the electricity on in their room so they had light. But we didn't change our staffing model for this one person. And so what we have here is, relative to our total cost structure, variable costs are tiny. Revenue is easy to determine. It's $2,500 per patient day, or $700 for an emergency room visit. The variable cost, though, is the key, because the difference between revenue and variable cost is contribution margin. And that is, organizations that create thousands and thousands of mini contribution margins, they are the ones that are successful, because those contribution margins cover all of our fixed costs. So that, to me, and now when you combine kind of strategy 1, an abundance mindset, with strategy 2, the focus becomes growth. The hospital I was at yesterday and today in here in Western New York, they have gotten caught up in a expense management mindset. And so what happened is they went from kind of breaking even, making a little money. And as things tightened up during the pandemic, they hyper-focused on expenses, whereas their revenue remained flat at about $27 million for the last 3 years, while their expenses rose. And they could not think about how to grow, because their entire culture was around cut expenses, cut services. And so they got themselves in a world of hurt. And so that's why they called us in. But I mean, I wouldn't say that the CEO was scarcity based. It was that she didn't know how to think with an abundance mindset. So with that, understanding the economic philosophy, and then strategy number 3 is on the next slide, Lindsay. excuse me, this just kind of demonstrates this idea that volume, the orange bar coming up at a fairly sharp angle, this is your revenue line. And so what happens is as you push out volume, you go from one emergency room visit to the second, generating $700 of revenue, going to a third, $2,100 of revenue. Where most of our expenses, or our expense line, because 80 to 85% of our costs are fixed, our expense line starts way up on the y-axis over here. But every incremental unit of service, our costs go up a little bit. Let's say 15 cents for every dollar of volume gain. By definition, if we are able to keep our, kind of grow our volume out beyond the point where it passes our fixed costs, our organization is going to be successful. Again, having that fundamental understanding tied in with that abundance mindset drives right into one area for improvement, and that's figuring out how to capture lost market share from our rural communities. Next slide. The third area, and this is one where you could have an abundance mindset, you can understand economics, but if we don't drive measurement into the bowels of our organization, in the words of the chairman of the company that I left 27 years ago, he was a physician in Western New York, and he said, Eric, in an organization that doesn't have measurable outputs will be driven by politics in decision making. And he, to this day, 27 years later, his comments stand true. And so performance measurement is an opportunity to shine a light with data on all areas where decision making is critical. So back when I went to school at University of Rochester, the Simon School, the big philosophy was this organizational culture, organizational design. And the theory around organizational design coming out of the Simon School was that there's a three-legged stool of decision rights, performance measurement, and compensation. And so if you think of a three-legged stool where you have decision rights, in our healthcare organizations, you can either centralize decision-making or decentralize decision-making, pushing decision-making down into the organization, where information there is critical for effective decisions. In our healthcare, the goal is to push decision-making down into our organization. I'm going to jump over to compensation. So if we're going to do that, we are going to want to tweak our compensation, recognizing extraordinary performance by those who have, served on the best interest of the organization. And so we want to tweak compensation. The third leg of the stool is if we're going to push decision-making down, if we're going to reward extraordinary performance in compensation, then there's two levels of information to share this performance measure. One is information to the managers making decisions to see the results of that. The second is having information at the senior leadership to make sure that we're minding the store here, that everything's getting done effectively. And so it's this middle bucket of performance measurement that often is lacking within our organizations. And when this is something that's spearheaded and really driven, we're going to see that politics being taken out of decision making, and we drive performance with data. And so, again, as I step back in all my travels, organizations that are successful in these three areas, abundance mindset, a understanding of what drives economic performance and financial performance, and then measurement to drive out politics from decision making and drive in performance. Those are the three keys to the kingdom that are consistent over time. So, yeah, Lindsay, you want to jump to the next? I think we're gonna. So, again, we have, it's Jogwater. We have a presentation. It's about a 3-hour workshop presentation, but it looks at all these different areas. In all our travels, there's best practices around every single one of those. You note that economic philosophy, kind of inpatient services around measurement, right? Are we getting, have we developed a care spectrum? Are we measuring our inpatient census and tracking that as a key performance indicator? Are we looking at a 10 to 12% ER admission rate? It's acute combined with observation. All of these areas are areas for improvement within our rural hospitals. Again, focusing on abundance, economics, and measurement. Next slide, please. I
Great.
think you're going to take it from here, aren't you?
Yeah, I'm going to drive this one home. So thanks, Eric, for really setting the stage. I think, some of the key strategies that, we've seen that are really can support some of those three concepts that Eric just mentioned of successful critical access hospitals, but some also meet, the guidance related to the flex financial and operational part of the grant, and some critical access hospital specific approaches that we've seen that are really impactful to organizations is the financial and operational assessment. Really that focused, rapid kind of analysis of the whole organization as a whole. I know Eric likes to describe this as a mile wide and an inch deep. Really touching and providing opportunities for operational and financial performance, and really capturing, the opportunities around that growth mindset, and that abundance mindset. That same evaluation can be applied to rural health clinics as well, really focusing on their operations of their practices, operational and financial improvement, as well as care optimization for rural health clinics. Other strategies that have worked, very cost specific, hospital specific, is around service line assessments, return on investments, again, touching on some of that growth mindset. What is it that we want to look at as a critical access hospital that are going to meet the demands of our service area, our community? Is there opportunities for growth around there? A swing bed program evaluation is really, we think, obviously the economics of a swing bed program for a critical access hospital, the value proposition, and really how do you optimize and grow those programs? And then more so on the finance side, a cost report review and strategy around the cost report, charge master review and strategy. And then also, how Eric touched on some of the changes that are happening in the payment system side. As we continue to see more and more rural hospitals enter into alternative payment models, value-based care programs, what does that look like from a kind of a financial modeling aspect? And then also, what's our service area, our market tell us about the types of services, our community, and having those kind of service area assessments to be done to really understand, is there opportunities down the road? Maybe it's not there today, but based on changes that will happen geographically and demographically within our service area, is there opportunities around future performance as the population does change? Secondly, and not necessarily critical access hospital, one hospital specific, but really education. I think there's so many opportunities. Eric spoke to, that performance measurement culture, the really elevating department managers. So opportunities around department manager training and education, the finance, cost reporting, budget creation, things that they're, if we're going to tell them that they're responsible for a clinical department or a department within the hospital, we want to arm them with the best materials and arm them to be kind of owners of their businesses. So that financial education. Also, leader and manager performance kind of assessment and training as well. Oftentimes we see that a manager, the hospitals have promoted somebody within to be a manager, but it might be just somebody that's been in the department as a lab tech for 20 years, and now they're going to be the manager of the department, but they have no management experience. They have no leadership training. They have, and making sure that they are the right fit for the organization. So having some of that work around leader and manager performance improvement as well. And as always, as Eric also said, the importance of performance measurement, needs assessment, leveraging financial data reports, and to really determine, as was presented earlier, kind of the financial state of the hospitals within your state, and then on an individual level as well. And then lastly, and I think my favorite, as a core, key strategy to consider, to support financial and operational improvement of the critical access hospitals is around network activity. And I personally feel that creating networks is really drives a lot of change when you get groups of like-minded individuals around a table to be able to kind of have these coordinated meetings, address their critical access hospital specific needs, share some industry best practices and kind of what's going on in the market to really help the overall state of the network in the critical access hospitals within the state. And then the same can be true for specific, revenue cycle. Revenue cycle is the engine that's going to drive a lot of the financial performance of an organization, and having those, again, really focus kind of revenue cycle management networks, both on the hospital and clinic side as well, could be something a key strategy to implement. So with that, any questions?
Well, I just want to, may I just go back and just explain? So that graphic that Lindsay was sharing, for the last probably 15 years, we've been working with all the critical access hospitals in the state of New York with Karen Madden and her team. And what this is looking at is every quarter, all of the critical access hospitals in New York submit financial data. And we look at about 8 to 10 different measures. And each of the hospitals' name, and we blinded it for purposes of this presentation, but is in that dark blue shade on the left of the graphic. And then this is their financial information going back to full year 17, 18, 19, 20, 21, 22, and then comparing to a target of a 2%. And you can see on the kind of the bars on the right, this is the variance each hospital had from the target of 2% based on the last quarters of information. And what we found is when we present this in New York, we'll have each, let's just say one hospital had an extraordinary first 6 months of the year. We'll ask that hospital to say, okay, what did you do? What happened here? Were you able, how did you grow your outpatient volume? You brought in a new surgeon or something like that? And they all get into sharing what's going on. And it's a, when people share within their peers rather than having consultants talk about it, it tends to be much more effective. And so, Karen in the New York State Office of Rural Health, we've been doing this, and it's been a very successful. And most hospitals come to these quarterly meetings, and we've been doing it. Gosh, if Karen's on, I don't know how many years, but it's been a long time. Back to you, Lindsay.
I think that's it. Thanks, Nick. Thanks, Eric.
Excellent. Thank you both so much. There's a lot of information covered there, but one of the unique things about the Flex program and CAHs in general is that the out-migrations are not from the CAH that's in their state. It's the major health systems that they're really trying to compete with. So to leverage that CAH network and them to learn lessons from each other, what's successful, what isn't, and to fully integrate performance management within their entire organization of how they're driving to really, whether you want to talk about rebranding or really establishing a presence out there within their community of the reason why patients are satisfied and they want to be here. They're an exceptional care coordination. And like Eric mentioned, this care spectrum where, we're ensuring that we're capturing all those patients that are routed through our primary care of our rural health clinic and really addressing their from birth to death, their entire lifetime spectrum of care in an exceptional patient-centered way, and setting that precedence is to compete with the large health systems. All of that is critical. So thank you both so much for sharing your insight and perspective from just working with these CAHs every single week. We greatly appreciate it. And with that being said, we've got a privilege of hearing directly from our CAH administrators, and we've got we got David Mance with Dallas County Medical Center on the call with us. David, hello, thank you for joining us. And we've got Miss Teresa Grimes from Washington County Hospital and Nursing Home on the line with us. Both of these CAH administrators have done an exceptional job at transforming their organizations. They are highly competitive in the space, and they have done just a phenomenal job at expanding service lines, targeting market growth opportunities, and this abundance mindset that Eric and Lindsay were just speaking to. They are able to compete with the neighboring health systems because they've focused on culture and they've focused on performance, and they've done an exceptional job at having cross-functional teams to work together to meet those strategic intent of the organization. So very happy to have you both on a call with us today. For the remaining time we have here, what we'd like to do is just hear from both of you as far as what your experience has been, and really what we're trying to connect the dots. The intention behind this here is we have our flex coordinators on the call. At the end of the day, what the flex coordinators, what we really want to hear is how can we help assist you the most? What's the highest value TA we can offer within our flex finance and ops work plans to help support CAHs financial sustainability and really success across the country. So what we're going to do is walk through a few scenarios and questions we have here, and we'd love to hear, what you've found to be most valuable, highest value to you, and how the Flex program can continue to support CAH success in the future. So thank you so much for being with us today. Yes, sir. First of all, one of the things that we've, I'll just kind of segue off of this conversation Eric and Lindsay spoke to. Performance management. Can you both please tell the group here what really have you found to be most successful at building this kind of performance management system within your organization, so that you got your entire team is focused on that, whether it's physician performance incentives around their compensation, or whether it's cross-functional teams? We would certainly love to hear what you found to be most successful at capturing those covered lives, how you're building out this, chronic care management and behavioral mental health, all those things. Please tell us what you've really found to be most successful here post-COVID in that. Now, David, I'll let you go first if you like, sir.
Absolutely.
Thank you.
Well, number one, thanks for having me here. I'm sorry I'm getting over a little issue, but my speaking voice isn't the best today, but I'm really, really happy to be here. I've had the benefit, guys, of the things that Eric and Lindsay talked about more than once, actually, at 3 hospitals, but it was over a long span of time, so I didn't bounce around too badly. But they've been incredibly helpful because I'm right now, I'm in Fordyce, Arkansas, a town of 4,300 people. So many of the people in our leadership have been here a long, long time. And like Lindsay alluded to, healthcare is pretty bad about the Peter principle, they call it, when you just elevate people to their point of incompetence at some point. They were a good nurse, so you make them a charge nurse. They did that well, so you make them a director, and they did that well, and you make them CNO. And eventually, without the proper training and such, we all get to that point. But we've got great people here, but we needed the direction that the team brought us through the Resource Center. We needed help in broad organization of that performance management. So when before the team got here, I had only been here a few months, and like I said, I've done the program before, so I remembered, and we were headed down the road in some ways, but they took us to new levels. Like, no directors were getting budgets every month. They basically say, keep my budget the way it was last year, and we'll see what happens. So we got a little more strategic on budgeting, but we also pulled them into the process of measurement and looking at KPIs, looking at their budget, explaining variances, and we continue to do that. And it has made a huge difference when they realize they are running a business called the lab or radiology. then they take it a different perspective and they take it a little more personally and own it. So that really helped. So we're doing that and looking at variances from month to month. Board education was something that they brought to us, and vital for our board members. Healthcare is so challenging to understand, and particularly healthcare finance. And when you take a school teacher and put them on the board, it takes a few years to really understand. So we've really stepped up our board education processes and monthly education for the board. A lot of it around finance and cost report and what a critical access hospital is versus what the big hospital in Little Rock is and how they work different. We also had a lot of leadership training. A lot of our leaders this past year, we kind of call 2023 the year of building our team. And we set several through the online courses through the resource center. So that's vital because it's all just continuing to grow in knowledge and experience, particularly when you're isolated in a rural area like we are. You know, we had huge technical assistance in telehealth. That's actually continuing. And we are in the final year of the program with the Resource Center. And we got a lot of support and direction from them, helping us assess telehealth platforms. And we've made our decision on moving on with that. And we're about to do the same thing with our electronic medical records, which we're having a lot of trouble with. They're going to assess our organization for need, and then they're going to assess 3 different systems and help us see which would best meet our needs, as well as the 5-year cost of ownership. So I've got to give Teresa some time. I appreciate it. I'm happy to answer any questions, but I can't wait to hear what you say, Teresa.
Thank you, David. Absolutely, Miss Teresa. Washington County, I know y'all are just crushing it too. Let's hear how you approach it.
Thank you, Nick, and thank you, David. And I just want to take a moment to thank all of you flex coordinators. I know that you have a challenging job. Sometimes just trying to get all of us CEOs on the same page is like herding cats, and I get that. So I just want to take a moment to say thank you for what you do, because your job is very, very important. And we couldn't do what we did without you. So I've had the fortune of working with Lindsay and Eric too for many years, and everything that they've said today and presented is spot on. So we've had that pleasure of working with them. One thing that I think that complements everything that David said, Eric and Lindsay, is just the spirit of transparency. Being transparent with your board, your employees, your managers. We work together. We have an annual strategic plan. We do quarterly leadership development institutes where we go over our strategic plan. And we do a quarterly town hall meetings, which are the employee forum meetings. So they know the good and the bad and the ugly. So as we're talking about where we're at, you know, and we use the Studer pillars. So we've worked diligently on the Studer pillars, you know, of the quality and focusing on quality, focusing on the finance and growth, the staff, the patient experience, and we've added community and safety into ours. So all the things that everybody's talked about, but some of the specifics, I think I want to mention that has really been good for us in the flex grant dollars. And we only have 5 critical access hospitals in Alabama. So Lindsay mentioned networking, but I can't tell you how beneficial that's been for us to network together in the state, but at the Mid-South conferences that you guys allow us to do. And from that, we hear wonderful speakers like Eric and them that help teach us. We did Cost Report 101 training. If you haven't done that recently for your staff, I think that is great to understand what Eric is saying, how we do the variability and all of that. So understanding, someone's mentioned education. I mean, so all the points that's already been mentioned, I think are our critical success factors. The biggest one is getting comfortable being uncomfortable and letting everyone on your team, including your community, know where you're at. I think has been, you know, getting everybody behind you. Your community wants you to succeed. Your board wants you to. Your physicians want you to. Your employees want you to. So finding that common ground of how we can improve things. And again, just all the things that's already been said. We were fortunate, we've done a lot of grants through COVID. So in addition to those dollars, we've done some USDA grants, we got some congressional funding. So always looking at how we can get some more monies to order to improve things. So I too am happy to entertain. We have lots of ideas and thoughts, but I think taking the golden nuggets that everybody has said really plays a factor. And I'll speak for David. I know David and I, either one, would be happy to talk to any of you individually. I don't think we have the monopoly on it. I appreciate Nick choosing us to speak today. And I want you to know he did that because he cares about you guys and he wants you to have the tools and the resources that you need to make your states better. So we're very fortunate to work together and to network. So thank you.
Thank you both so much for that. And, you know, you mentioned several things that I want to just, while we got a couple minutes left here, go back and unpack. One is the both of you mentioned the training and really building capacity of the staff. That is so, your team, we used to call it decentralized command, but basically it's the same concept. You're building out the leadership capabilities of your team to really, for them to drive this really performance-based culture. So of course, all, you know, down to the department level, we would like to hope that all CAHs out there in the country right now at this point would have this performance-based system integrated, and they've got department level managers and variance reports that on a monthly basis, they're looking at where are we at, where do we need to be, and what can we do to actually implement a change here to meet that intent. But unfortunately, that is not the case across the country. And that, so we absolutely, if your state's hospitals have not built that capacity yet, it's not going to be possible to compete with the major health systems if they don't have those fundamentals covered. So when it comes to optimizing the revenue cycle department, RCM management, we mentioned the cost report and a charge master and making sure we've got our price transparency straight. We've got strategic pricing in place for our payer mix. Those things are really fundamental at this point, along with this having the cross-functional clinical and business office staff that are on the same page about here's what we're going towards in terms of our KPIs that we've identified for our organization. So all of that feeds into now we're developing a presence and the community engagement factor where we're rebranding or really gaining momentum in our marketing intent to reduce those out migrations and to really expand our service market. So the y'all both mentioned a couple things, and one was this kind of service line expansion around telehealth. Certainly there's massive opportunity there. The flex coordinators base much of what they've been able to ascertain off the Compass data, the state needs assessment. And when it comes to assuming we've already helped our struggling health systems to build that kind of strategic performance management infrastructure, and we're looking to expand this volume that both Eric and Lindsay were speaking to, can you both please speak to where have you found to be most helpful in your rural communities as far as service line expansion so that you can grow volume? Can you please speak to that?
Sure. The areas that we've expanded, number one, we were able to hire a psych nurse practitioner. And so that's kind of been big because we've gone out even to other clinics in the region and let them know that, you know, she has prescriptive abilities, and they're very happy to hand their behavioral health patients over to her just for that. She doesn't do counseling, so we don't take them away from anyone. And her service has really grown. She's been here a year. The telehealth is an area we're really excited about because we are working with our school now to put a telehealth unit in the school, and the school nurse will actually do the visit on their end and have access to our physicians in our clinic. So if they've got a wound or you know, an eye to look at, or if they're wheezing or whatever, we'll have all those tools, the amazing stethoscope and a scope that you can see, again, skin lesions, back of the throat, ears, eyes, whatever. And the provider on our end can determine if, you know, it's something they could write a prescription for, or if they need to actually come to the clinic, or if they need to go to the emergency department. We're really looking forward to that because there's so many children in these rural areas that just don't get health care until it's an emergency room visit. So we're really excited about that. Teresa?
As far as service lines, one thing that I think everybody could do or take a look at it is adding medical detox program. It is a medical diagnosis, so you don't have to have things special other than a program, and of course, you know, your protocols and things. But we've added a medical detox. Again, it's a medical patient that really has helped us with our inpatient. Our state has done a lot to really help us as a state with our swing bed programs, with growing the swing bed, understanding it, improving the quality needle and that. Telehealth, unfortunately, we've probably not done as much. We know we haven't. We do a lot of mental health with telehealth, but other than that, unfortunately, not a lot has expanded at this time.
All right, that's fair. Thank you both. So the, you know, we heard IOP at the beginning and now we're here, and that's, I mean, we all know behavioral mental health is not going away across the country right now, and telehealth expansion absolutely needs to be an option worth considering, whether it's in schools or in prisons or additional service line offerings or otherwise, as a mechanism to grow volume. Thank you both so much. We have just a couple minutes left here. We are going to launch the polling. Thank you so much, Caroline. Teresa Grimes, David Mance, we greatly appreciate your time and effort with us today. We certainly, we got some more questions in the chat. We will circle back and follow up with any of you who had questions we didn't have time to quite get to today. We've got a few last slides here I want to share, just to kind of bring home what we have discussed. Can you all see my screen there? Okay. All right, excellent. Okay, so of course, the needs assessment is driving it along with the research and all of your data collection, leveraging Compass and communications and discussions with your partners to help identify what's the highest need and what's the potential highest value TA you can offer for your state's program. Along the same lines of being systematic with that, you know, we certainly want to consider a robust chronic care management plan, fully leveraging this care spectrum or care continuum through our RHCs. Primary care is absolutely from Amazon to CVS to Oak Street, they're all coming after primary care. So CAHs have got to focus on building capacity in that area and really developing the partnerships and a presence in the community that is patient-centered, patient-focused, high-quality care so that they are reducing the out-migrations and being competitive in that space. Along the same lines, the FORHIP and HRSA have done an exceptional job of setting you all up for success this next grant program year. We've got short, intermediate, and long-term outcomes listed. And the expectation is that you focus on the ones that are in the highest need. We've got lots of resources here that really on our landing page around all the, if you're looking for options, the structure document gives multiple examples within your work plan. HRSA has done a fantastic job of the work plan template. You've got drop downs listed for possible investments. And of course, the center can also give you an unbiased recommendations for multiple vendors, including Stroudwater out there for you to consider for a potential addressing the needs that you all are identifying. So with that being said, please complete the polling if you haven't yet already. This is certainly something that's going to help us to continue to offer exceptional service to you moving forward. And we greatly appreciate all of the speakers' time today and working with us. we've got just a couple minutes left here. Caroline, do you see any questions in the poll for any of our last minute speakers can answer? Let's see, we almost got our poll straight.
Yeah.
Anything in the chat there?
Not that I can see, Nick, no.
Okay. If we have some further up in the chat that we haven't had a chance to, again, we will circle back with you in a response to that. But we greatly appreciate all of your time today and certainly want to wish you continued success for your program. Please do your research, study as much as you can and make the best possible decision, informed decision with your state stakeholders to make it extremely high value and intentional investments within your flex work plan and finance and ops. And we'll do everything we can to support these CAHs here in the future. Thank you all so much for your time today. Keep up the outstanding work, and we'll look forward to speaking with you all again here soon.